Thank you for the invitation. Let me share my screen. So I've been invited to and asked to talk about pain and the management of pain. And it's a broad subject, as everyone knows, but I'm going to give you the basic behind assessing pain and the principle behind treating it as well. So the highlight of this presentation is first to identify the presence of pain and assess the severity of pain with properly document the pain in the pain scales. And to get introduced to the variety of different pain assessment tools and how to manage the pain as well. So before proceeding to the presentation, we need first to define what's pain. So pain is always the unpleasant sensory and emotional experience that is associated with actual or crucial tissue damage. Pain is always subjective, and it's always how the patient describes, and it could be acute or chronic pain. So always, I don't remember myself passing a day without having a patient coming to the emergency department without complaining of pain. So it is the most common kind of presentation. And we always underestimate scoring it or treating it. So don't focus on the injury and injury site. Don't focus on the pain itself because that might underestimate the pain and could undertreat the patient. So there are so many factors involved when the patient comes to your department. First, put in your mind that the age of patient is a factor, and their milestones and developmental stage they are in is a factor as well. The circumstances prior ED presentation as well is a factor, and the parent's behavior and interaction with the child after complaining of pain is also a factor. So there are basics. First of all, we need to assess the pain. When the patient comes and complains of pain, we need to assess that pain. After assessing that pain, we need to treat the pain. So the recommendations before that, we need to delay pain for diagnosis and so and so. It's not recommended anymore. Please, if patient comes in pain, go and treat that pain, because it will not delay your diagnosis and it will not change your differential diagnosis. So assess your pain, give it a score, treat that pain, and then go and find your cause. After finding the cause of pain, go and reassess the pain again, because after removing the factors that are involved, you're going to be surprised that the score can change from 8, 10 into 5 and 4. After reassessing the pain, adjust your treatment accordingly. So the pain assessment should involve the type of pain. So we need to know that pain is a nociceptive pain, so tissue damage, inflammation, or if it is a neuropathic pain and it is a primary disease. We need to know the site of that pain, and that will help us in our differential diagnosis. And the intensity of pain is really important, if it is mild or moderate or severe, because that will guide your treatment and treatment plan. And of course, the severity, if it is acute or chronic, and that will guide further future planning for pain management. So the severity assessment, if it is acute or chronic, if that patient came with acute pain, you're gonna notice that the pain is always reported by the patient, him or herself. And we use the pain assessment tools to evaluate that. If that pain is chronic, then you're gonna see that, you're gonna notice that it is reported usually by the parents themselves. And it has elements in the history as frequency, duration, severity, and impact on daily life. Saying that, we have to know that there are lots of tools available in the internet and our resources, the trusted resources, but we need to know how to choose the right one. choosing the wrong tool will help to underestimate the pain, and the child could be undertreated. So there are two types: self-reporting tools and observational tools. So for self-reporting tools, it depends on the child cognitive ability and the understanding of pain and how to measure pain. It is divided into age-based pain rating scales. So it divided into age groups, and 3 to 8 years of age, 8 to 11 years of age, and adolescent. So for the first group, 3 to 8, we use the face pain scales, which is the Wong-Becker face pain, and there are several types of it. This is one of them: 0 to 5, crying faces, sad faces, and happy face. There is the ones that is colorful, colored green, yellow, orange, and red for excruciating pain. Choose the one that is you have an access to, and and the one you're comfortable using. For the older children, 8 to 11, we use the numeric scales, 0 to 10. It's easy. Tell me to describe your pain. How do you scale it from 0 to 10? If it is 8, then it's moderate severe. If it is 0, then no pain. 10 is the worst possible. For adolescent, there is no specific scale, but there are some charts that will help. It's always obtained by history and the description by the patient himself about the location, the description of pain intensity, duration, frequency, and factors that that involved. And there is some charts for chronic pain, and you can give it to the patient, and they can document it themselves, and then you can have your score, intensity score, at the end. If that patient is nonverbal and cannot assess the pain, then we go for observational tools. So observational tools, the most common one used is revised face, leg activity, cry concealability, R-flag tool. And this is the chart. It is scored from 0 to 2. The observation involves 5 elements: face, leg, activity, cry, concealability. And we observe the patient from 1 to 2 minutes. If the patient is sleeping, we go beyond 2 minutes, and then we accumulate the score, and then we have the final intensity score. There are others that, like non-communicating children pain checklist post-operative version, and that the form, again, it depends on observation of 4 elements and then accumulate the numbers. And there is the pediatric pain profile. And for newborn to 16 years of age, there's the nursing assessment pain intensity. All of them are available, and they are available online. Whichever easy access, go and find one. Have it available for yourself whenever you have a pain complaining patient, and go and score that patient accordingly. So the goals of pain management: first, we need to reduce that pain. Patient came in excruciating pain or mild pain, please go give analgesia, reduce that pain, control it then. Don't let that patient suffer more, and then prevent further episodes of that pain. Management, choosing your way of treatment depends on, again, the type of that pain and the source of that pain, severity of that pain, and duration of that pain as well. So the principle of management: first, we have to put in mind that you don't assess pain only once. We have to do several assessments of pain. Again, if we eliminate the factors that affect the pain, then that will help us, that the score gonna change, and then we adjust our treatment accordingly. Put in mind, pain management is not always drug, So pain management should include non-pharmacological and pharmacological aspect. For non-pharmacological aspect, cognitive, behavioral, physical supportive therapies, And there are several randomized clinical trials have been evaluating patients who are going into needle-related procedures, and they applied psychological interventions with hypnosis methods, and they have noticed that it reduces pain significantly with stress. So it does work, and it is applied in several facilities like oncology and hematology department, and it proved its efficacy. So please try to try that in your practice. The pharmacological aspect, we always prefer oral routes for painkillers, and then side effects we have to be aware of and put in mind there are other drugs that can be helpful in certain conditions and clinical settings, like anticonvulsants for neuropathic pain, or antidepressant and anxiolytic for coexisting mood disturbances. Considerations when I choose the pain management is that, is the patient already on a pain regimen? Does he have a chronic pain? Does he have any experience with pain medications before, and did he have any adverse effect? If parental experience with pain management, and if they have any fear regarding any kind of medication. If there is non-pharmacological intervention has been used with that particular patient, and if it was helpful and working. The child's coping mechanism is important as well. And there are some social and spiritual factors in some cultures that has to be put in mind as well. To treat pain, we need to know basic physiology. We need to break the cycle in every aspect of pain physiology. So when there is a tissue damage, nociceptive pain follows a sequence of 4 events. The main ones are pain transduction, transmission, perception, and modulation. So note that it's not only about drug. Analgesia is a multimodal and does not just revolve around drug. For pain transduction, so the first part when I have a transduction, like let's say for example a painful stimulus like a trauma to a tissue, then the patient gonna release chemical mediators in the tissue, prostaglandins, substance P, etc., etc. Sorry, this triggers an action potential. So after that happens, and then we can stop at that stage. We can stop pain by applying simple first aid management. So for example, let's say if that patient came with burn, let's run that burn into under cool room temperature water for 20 minutes. This will provide pain relief as well as arresting further tissue damage. Let's say deformed fractured limb, please go and splint and backslap that limb during your initial assessment and before sending the child for x-ray. That's gonna relieve the pressure and tension and gonna decrease your intensity score for sure. If that patient have a clavicular shoulder injury, please go and sling him. And if that patient have a soft tissue injury, like an ankle swollen, please ice pack and elevate the ankle, and you will be surprised how much your score is going to be reduced. So at perception level of the physiology, then patient now recognize that they do have pain. And this is where the non-pharmacological aspect of pain management comes. So reduce child's perception of pain by distraction technique, develop a rapport with your patient, change the environment, put him on his mother's lap, go into his level of, at his level, talk to him with a soothing voice, use age-related stuff he's interested or she's interested with, use the mom, smartphones, bubbles, balloons, everyone knows how to sing rhymes of childhood. So these methods will distract the patient and will stop the perception of pain. For pain transduction, and this is the part when we use medications, and many agents are available and interrupt the transmission of painful stimulus. And it does depend on the age of the child and the level of the pain described or documented. So we can use topical anesthesia or systemic analgesia. For topical local pain relief, there are several agents, and topical use of lidocaine and adrenaline, usually for broken skin, and applied to wounds and lacerations. For tetracaine and tetracaine 4%, we usually apply them for 30 to 40%, and their effect will last for 4 to 6 minutes. And we usually use them for lumbar punctures and IV insertions. There are contraindication of usage, and they are like if patient had previous general anesthesia reaction or known to have cholinesterase deficiency. If that patient won't have a mucus like eyes, nose, mouth, avoid it. Don't use it. If the wound is more than 5 centimeters in length, we avoid them. If there is a concern of viability of the tissue, so crush or flap wounds, we don't use them as well. If that wound is 8 hours old, we don't use them as well. Obvious injury to associated structures, bone, tendon, blood vessel, joint, or nerve. So if that wound is an open wound with the structures that's obvious to your eyes, don't use them. And for the ears, nose, genitalia, digits should not be, we should discuss it with the senior staff. And there are concerns about the perfusion and usage of this area, and because the evidence also showing less effect on extremity wounds. So the strategy, how do I choose my drugs and medications? So again, it depends on the severity, intensity, and child response to previous administered agent. So pharmacological therapy, if I want to choose which drug to use, then I have the intensity score. After having the intensity score, if that pain is mild to moderate pain, then we will go for non-opioid analgesia. And for moderate and severe pain, we'll go for opioid. In the non-opioid analgesia, the most common two drugs that is used everywhere in the world is paracetamol and non-inflammatory, non-steroidal anti-inflammatory drugs. And for opioid, put in mind that we always prefer oral routes, and it is used after refractory non-opioid analgesia and associated with specific condition like sickle cell disease and cancer, post-surgery and surgery. So aspirin used to be used, not anymore, and I don't believe anyone else who ever suggests aspirin since 1970 because of the association of Rett syndrome. So non-opioid analgesia, as paracetamol, comes in several forms: oral, IV, rectal. The dose is from 10 milligram to 50 milligram per kg every 4 to 6 hours. The maximum dose is 75 milligram per kg per day, 5 doses a day. There is a toxic level, so always go to your BNF and check your indications, contraindications, and proper doses, and avoid toxicity. For non-opioid analgesia, we do have 2 classes. The first class is non-selective, non-steroidal anti-inflammatory drug. And the second class is COX-2, a selective COX-2, which is rarely used in pediatric age group. For non-selective, non-steroidal includes the common 2 drugs is ibuprofen and diclofenac. For less commonly used are ketoprofen, naproxen, indomethacin, and ketorolac. So there is an anti-inflammatory properties for the non-steroidal anti-inflammatory drug, which makes it superior on paracetamol. So if that patient have a signs of inflammation, choose ibuprofen and skip paracetamol. There's adverse effect for chronic use, and the most common 2 gastrointestinal bleeds and renal toxicity. The opioid. So to prescribe an opioid, we have to have a precautions. So the duration of treatment, usually post-surgery, There are some unsafe practice regarding the usage, storage, and disposal of opioid that are prescribed to children are common. And chronic pain control should always supervised by pain management team and experts. Opioid choices depend on intensity again, duration of pain, preferred mode of administration, associated adverse effect, and prior experience. So note and put in mind that oral route always preferred. Acute pain, short-acting agent, go for that. Chronic pain, choose the long half-life agent or sustained release agents such as methadone or fentanyl. So several forms of the drug. We always the most common two is morphine and fentanyl. In our emergency department, we use the morphine fentanyl. The fentanyl have an intranasal form, which makes it more superior, and it does have a conscious sedation, and we use it for some invasive procedures as well. Agents which are not recommended, codeine and tramadol, that doesn't mean that we don't use them, but in 2017, US Food and Drug Administration issued warnings and contraindication of the uses, and children are under 12 years of age. Other facilities like Health Canada and European Medicine Agency as well, they follow the same recommendations. But we do use them in patients who are more than 12 years of age, and we particularly avoid them in obese patients with obstructive sleep apnea and severe lung disease. With patient who has just followed a tonsillectomy or adenectomy in children of any age. And that's because of the breathing problem it causes. So initiating a dose of opioid, first we have to assess the pain. If it is constant and severe pain, we go for short-acting agent and we give it every 4 hours. And after 24 hours to 48 hours, 5 to 6 half-lives, we go and calculate the daily dose and requirement. After calculating that, based on the last 24 hours requirement, we can adjust our treatment. So based upon the child's response, first, we can increase 25 to 50% per day, can go up to 100% for very severe pain. Till when? Till we have an adequate analgesic analgesia or any side effect is intolerable. And we should all know the side effect of opioid: nausea, vomiting, commonly constipation, sedative, cognitive dysfunction, respiratory depression, myoclonus, hyperalgia, pruritus, and toxicity is common, overdosing, and naloxone is used as 0.1 milligram per kg IM or IV. So again, the doses for morphine, 0.3 milligram per kg every 3 to 4 hours, and for IV, for oral, and for IV dose is 0.05 to 0.1 milligram per kg every 2 to 4 hours. Fentanyl, 0.5 to 1 mg per kg every 1 to 2 hours, and there is an intranasal form as well. So we have developed an algorithm in our emergency department to deal with the pain and pain management. So if the patient came with pain, we go and assess that pain. If that patient can report and if that patient is non-verbal, then we would go for the observational tools which are available in our emergency department. And then we will document that pain intensity score. After that, if that patient can self-report, we would use age-related score scales, the numeric or face-related scores, and then we will have our intensity score. After having the intensity score, we would start non-pharmacological aspect of treatment. So distraction, splinting, dressing. After that, if that patient going into procedure, we would use nitrous oxide. If not, then we would go for pharmacological aspect. How do we choose our drugs? Depends on the intensity score. So if that intensity score is mild pain, 1 to 3, then we would go for oral paracetamol and ibuprofen. If that is a moderate pain from 4 to 7 score, then we would go for IM fentanyl for any child more than 1 year of age, and then oromorph or oromorph. If that did not help, then we would top that with ibuprofen or paracetamol oral. If it is a severe pain, 8 to 10, then we would go for fentanyl again, or IV morphine, plus paracetamol IV or ibuprofen. If that did not help, then we will call the anesthetist and we would start opioid infusion. It doesn't stop there. After an hour, we have to reassess our management and then do another score and adjust our treatment accordingly. So always go to your BNF for your doses and indications, contraindications, and precautions. To conclude everything, I'm going to tell you a short story about Jamie. So Jamie came to our emergency department after having a fall. He was playing in the trampoline with his sister. At presentation, he was distressed and crying. In the triage, his mom was stressful and distressed as well. So he was playing. This is the circumstances leading to ED department and the mother reflection on the child's behavior. Factors that affecting pain assessment, actually. And then moms is anxious and worried, factors reflecting the child as pain assessment as well. So we take Jamie to a minor area and completed his assessment in a calmer, better environment. The mom got calmer, and that reflected on Jamie, and Jamie somehow settled in, and he's no longer crying. After his examination, while observing Jamie, we saw that he's holding his left elbow fixed in flexion. So we asked him where is the maximum point of pain, and he pointed to his left arm. He did refuse to move his arm, but any other kind of examination have no concerns. So on palpation and careful examination on his left arm, he did get a bit distressed and was a bit in pain to touch. So we showed him the Wong-Baker scale, and he pointed to the orange sad face, which indicated a pain score of 8. So the mom, moving the mom into a better area, this is a non-pharmacological environmental calming effect, and using the proper age-related pain score to give the proper score after removing the factors that affecting the child's pain. So we have given him the proper pain score according to his age and pain. After doing that, Jamie, we suspected that Jamie had fracture.
Abrar, you have like 1 minute to wind up because we have a few questions.
That's two slides more.
Be quick slides. If you can.
Yeah, last two. So has a fracture to his arm, perhaps a supracondylar fracture. So we gave him we gave him fentanyl and paracetamol, and that's because of the pharmacological pain management according to his pain score. And his mom played video, and that was non-pharmacological cognitive behavior, distraction. And we applied an above elbow back slab splint, and that's to stop the pain transduction. Again, we reassessed the pain. The score went into 2. We sent him to X-rays, and we gave, the score was 2. After that, we referred him to orthopedic, and after referring, we wrote further management for the word of the drug. So this is a proper follow-up plan for pain management. So take-home points, we always underestimate pain evaluation, and we treat our own perception and estimation of pain. So please, this is a wrong practice. We have to use a proper pain assessment tools. Don't hesitate to give proper analgesia. Always refer to your BNF guidelines. Morphine is given for severe pain. And thank you. Thank you for listening, and hope from today we're going to use the proper assessments, and we're going to have initiate the proper management of pain.